Hello, and welcome to another episode of Hematology Horizons. My name is Elissa Baldwin, and I'm the Director of National Patient Education at the Leukemia and Lymphoma Society. Today, we'll be visiting with Dr. Luke Fletcher, a hematologist-oncologist at Willamette Valley Cancer Institute in Eugene, Oregon. Welcome, Dr. Fletcher.
Thank you so much. Thank you for having me. I'm really excited to be here.
Thank you. So our episode today is on acute myeloid leukemia, or AML, and how it's treated in the community setting. Could you tell our viewers what AML is?
Sure, absolutely. So AML, or acute myeloid leukemia, as you said, is a cancer of the myeloid stem cells. So there's two broad divisions within our blood cells. It's called the myeloid stem cells and the lymphoid stem cells, and that's what becomes all of the blood cells in our body. And so AML, or acute, is a aggressive form of leukemia or blood cancer that is derived from those early type of cells that have the ability to become any of those certain types of myeloid type cells. That's a lot of your white blood cells, like your neutrophils or your monocytes. It's your red blood cells and it's your platelets. All of those come from the myeloid lineage. And so it's an immature cancer, usually defined by greater than 20% of those immature cells or blasts that are known. But also we're becoming better and better at defining it on a molecular level. And that, as we'll talk today, is about some of the treatments. It's becoming a much more molecularly driven disease.
Okay. So what are common signs or symptoms that may cause someone to go to the doctor and then be diagnosed with AML?
Yeah. So a lot of it has to do with what's happening in their blood and their blood counts. And that's what's driving a lot of the symptoms. So unlike some other types of cancer where you're going to notice a lump or a mass, or you may notice that there's a new increasing pain in the bones, often it's driven more like patients are really, really tired. So they're noticing potentially easy bruising because their platelets are low. They're noticing fatigue because their red blood cells are low, or they're noticing because their white count is really high that they're fatigued and kind of having flu-like symptoms, maybe some mild fevers or chills, or even overt fevers can be definitely present when you have that aggressive form of leukemia. But sometimes it can be kind of vague until it's really there and they're really worn out from the disease itself.
Right. Okay. So what are the current treatments for AML? And that is dependent somewhat on genetic mutations, right?
Yeah. So this has changed a lot in the landscape over the recent past. And so it's divided up really, first off, diagnosis, which divides then into what their risk category is. And I think of risk in leukemia the same way I think of staging in other types of cancers. And it has a lot to do with actually when we think about people who have breast cancer or who have prostate cancer, and people are used to that stage 1 through 4 system. Well, in the blood world, anything that is stage 4, let's say in a breast cancer, involving the bone marrow. So there's a bone marrow that shows there's disease there. That's stage 4. That means every single blood cancer we have is stage 4. That doesn't tell me anything about how to manage that patient is the issue. And so we've had to come up with different systems to tell us what we need to know about staging. And so that's what risk stratification really is. And so the goals of risk stratification are to tell me, hey, what is the prognosis of this patient? And what therapies are they most likely to respond based off that prognosis? So for AML, for instance, for patients who are potentially eligible for chemotherapy, so that's going to be some of your younger patients, not your really elderly patients, there is certain criteria called the European Leukemia Network, or ELN criteria, that divides patients into favorable risk, intermediate, or unfavorable risk categories. Those that are favorable risk are more likely to respond to chemotherapy than those who are unfavorable risks. In addition to those favorable risk patients may be cured with chemotherapy alone via induction chemotherapy followed by consolidation, whereas an intermediate or an unfavorable risk patient, if they get into remission with induction chemotherapy, is discussion of an allogeneic stem cell transplant for curative therapy. And so we'll define someone based off their chromosomes as well as the certain molecular mutations, how we think about what treatment is the best for that patient. So age plays a role, but also are they fit for induction? That's where the ELN criteria comes into play. For those that are unfit for potentially induction based off comorbidities or via age, the selection of therapy is often centered around azacitidine, venetoclax, so hypomethylating agent, which has been the standard of care for a lot of years, I should say, in addition to venetoclax, which came into practice about 3 or 4 years ago, which I call it basically it supercharges the azacitidine, significantly increased response rates and overall survival increase, actually, whether they potentially are transplant eligible or even not, which most of those patients are not transplant eligible. The real paradigm shift beyond that's been the staple is chemo or not chemo, and based off those risk stratifications, is the molecular component. And that molecular component, as I mentioned, comes into play when you talk about risk stratification, but also comes into play when you talk about actual treatment selection. And we have multiple actually therapeutic options based off those molecular targets. And so as I mentioned earlier, AML has become a very molecular driven disease, not just in diagnosis, not just actually in prognosis, but in therapeutics. And so we have multiple genes that we actually look for that tell us potentially therapeutic options. So for instance, we have drug options for people who are FLT3 ITD and TKD positive. There's multiple options in combination with chemotherapy, and there's really promising evidence that's building in combination with azavenetoclax with FLT3 inhibitors as well too. That's currently in trials, and it looks very promising for a really high degree of response rates. IDH inhibitors, so IDH 1 and 2 are an active area that has options both in those that are not potentially chemotherapy candidates in the elderly, so in combination with azacitidine, or potentially looking in combination with azavenetoclax or with induction chemotherapy. Those are all being investigated as well. The one that is probably the most paramount or has seen the most interest lately has to do with something called menin inhibitors. And menin inhibitors specifically, obviously they inhibit menin, but what menin actually does in leukemia or in AML is that basically mutations in the menin pathway prevent basically those cells from maturing. And so those cells stay immature or blasts. And so we see that this is a common concept we see within AML that basically prevents cells from maturing like normal, and basically it's a differentiation block is what it's called. Similar actually what we see with IDH, and IDH 1 and 2 mutations is a similar type of process. The specific mutations in this pathway we see is MLL rearrangements and NPM1 mutations. And NPM1 mutations are seen in about 25 to 30% of patients. MLL rearrangement is about 5 to 10% of patients. So this is something that could affect somewhere between 30 and 40% of our patients in terms of potential options for them. But menin inhibitors work by basically blocking the differentiation block and having those cells mature to normal cells and then die off. And we actually have one that's already approved for MLL rearrangement. It's a drug called revumenib. It was approved in November of last year. But this is just the start of the dam with menin inhibitors because there's a bunch of them currently in development. There's really 4 main ones in development. Okay. Something called revumenib, which is the one I just mentioned. Something called ziftomenib, bleximenib, and then enzomenib. And those are the 4 that are being developed right now in active clinical trials. And I think one of the most exciting things that's not ready for prime time yet, but I expect to be an area of, that's going to be of intense investigation, is combination therapies with either induction chemotherapy, as we've done with like FLT3 inhibitors, or potentially as well with azavenetoclax, with hypomethylating plus venetoclax. The early data that we actually know from a couple months ago showed significant response rates. We're talking complete response rates in the 90 to 100% range.
Wow.
in frontline treatment for those that were on the trials. Now, small numbers, but very promising to say the least. And even in the relapse refractory setting, there was a trial of an all oral therapy, which seems wild to talk about in the AML world, to have a 3-drug combination that was all orals. But it was an oral hypomethylene agent, oral venetoclax, and then revumenib all together in the relapse refractory setting had a complete response rate composite of 82%. And so we're seeing significant response rates, even relapse refractory setting or in the front line, that are even taking a good disease and making it even better. And that's what we want to do, is we want to push even higher. I said, 50 to 60% of people who are cured with frontline favorable risk, we want that 80, 90, right? We want to push that envelope as far as we can, that patients are, we're pushing for cure for our AML patients as much as possible.
That is so exciting. Now, the menin inhibitor that you mentioned that was FDA approved, who is eligible for that right now?
Yeah, so anyone who is relapsed refractory, so meaning that they've been through treatment before. So
okay,
whether
so
that's
not a frontline treatment.
Not a frontline treatment at this point, so either azavenetoclax or induction chemotherapy, then they would be potentially eligible for that. Now, obviously, in conjunction with that, you're always taking into account what is the best therapy at that point for that patient, whether a second induction is appropriate, or if they've been through induction, is azavenetoclax appropriate for that patient. It's always an assessment. The response rates are modest, but they seem to be relatively durable. So total response rate's about 40%. The complete response rate's about 20%. The fascinating thing about that, though, is these are in the trials was heavily pretreated patients. So most of the patients had been through both induction and azavenetoclax at that point. And of that patients that responded, a third of those patients made it to transplant in CR2. And so there's patients who had been heavily pretreated, and still a third of them
Yes.
made it to transplant, which is pretty amazing actually in regards to that. So,
Wow.
one thing that is, as I mentioned earlier, is the clinical trial aspect, right? So that's what's currently
Yes.
available out there in the relapsed refractory setting. Looking for a trial for someone for the frontline setting is I think it's something that is definitely warranted at this point. And that's one thing that I've really been passionate about is, why do I do AML in the community? And why am I passionate about being where I'm at and not in an academic center? And so there's really two big things to me. One of the things specifically is around coordination of care, is being a linchpin between an academic center where maybe they're going to transplant and then somewhere else, and having that specific expertise of an AML in the community is important to me. Mm-hmm. So I'm very lucky that I work in about 2 hours from where I trained. And so I trained at Oregon Health and Science University. I have a lot of close friends there, but that definitely helps that connection there. But that I think can be duplicated other places, and I think is important to be potentially duplicated other places of having those direct connections and coordination of care. But the second reason why was to try to bring further clinical trials into the community, is making an AML a disease that some things maybe have to happen in an academic center, but a lot doesn't. And taking some of that stigma, taking some of that fear in the community of those diseases, yes, and being able to give care to people where they live, and being able to then be with their support system and not having to travel multiple hours to get certain therapies. And so that can be as simple as we do a lot of almost all the patients from OHSU who come here get their consolidation chemotherapy with me locally. And we've come up with protocols to be able to do it outpatient instead of inpatient. And so we're developing ways and thinking innovatively of how we can give care to our patients locally as much, not just sending them to Portland, but it is sometimes necessary.
Yes.
But also extensive clinical trials. So we have a frontline trial with menin. And so it's a combination of venetoclax plus one of the menin drugs actually that is going to be open at our site hopefully in the next 1 to 2 months. And that is basically just illustrates the concept of, hey, we need to get these drugs safely in community settings and be able to do these outpatient safely. And so that's really where menin's at right now. OHSU has trials as well too. A lot of places have trials of these drugs frontline with combination. Mm-hmm. And we're really trying to say, hey, early evidence is very promising. Is it better than the standard of HMA venetoclax? Yeah. Which is where we're at right now.
Okay. So let's talk a little bit more about treatment of AML in the community oncology setting, like you were just talking about. Yeah. Now, we're in Eugene, Oregon. You mentioned that the nearest major research hospital is about 2 hours away in Portland. But there's obviously a large swath of the community that is, would see Eugene as the closer cancer clinic to be able to get treatment. So could you walk through with us how that would work for a patient if they were diagnosed here, particularly if they end up needing a stem cell transplant? How does that all work?
Yeah, so one of the big things I always evaluate early on as I'm trying to A, diagnose someone, and then B, select therapy for them. So and it gets actually to the broader concept of, I think one thing about giving care in the community, wherever you are, whether it's an academic center, whether it's here, whether it's Medford, wherever you're at, you have to know your community. And you have to know, not necessarily saying what we can and can't do, it's a lot of saying, how do I know what I need to do and then fit it to what we can do? So for instance, this gets a lot into like how I give blood transfusions and how I think differently. And so, like if you're going to have a delay in a blood transfusion of a day, well, maybe you have different goals for your blood transfusions because it's going to be a delay of a day, right? And so there's different things like that. You have to know your specific community to know, hey, how do I give that therapy effectively? And it may require thinking a little bit differently. It doesn't change the ultimate goal is I'm giving that therapy, but it may say how I give it is different. And so it's about knowing your specific community. And so what I've done actually is I worked really closely with my hematopathologist, so with my blood pathologist, and I said, hey, what resources do we have in terms of diagnosis? Okay, how quickly can we get information, and can we do better? That's the three things I basically said is that what do we have now and how can we even improve on that? Because as I mentioned earlier, one of the big things about both treatment and diagnosis is knowing their cytogenetics chromosomes. It's knowing their molecular mutations because that governs a lot about how we think about treatment. Yes. So as I mentioned earlier, unfavorable risk patients are actually less likely to respond to conventional chemotherapy, especially if they're on the border already. That may be a patient that we push towards either trial or venetoclax versus actually giving them induction chemotherapy. therapy.
Okay.
And so those some of the decisions I'm looking at up front. So their age, their comorbidities, as well as their molecular mutations to make a decision on saying, hey, if they're an induction candidate, often they'll go to OHSU for initial induction, or if they're not, they'll stay with me locally and get aza/venetoclax locally. So there's a subset of patients that don't necessarily go up there immediately, especially with trial options unfolding. But to do that, I need to know what their diagnosis is, but not just what their diagnosis, what their molecular is. And so what we've actually worked with, and I have to give a huge shout out to our pathology consultants here. So our hematopathologists I work with are very, very diligent. They have very similar mindset to me in terms of how do we give better care. And so we looked actually is that, hey, we don't have a lab on site, a molecular lab on site like an academic center would have, but what commercial product can we use that can give us similar answers in a timely fashion? And so we went through actually a bunch of different products and found, hey, this one, we can get approvals quickly. It comes back in 7 days. And so that was initially what we did was, hey, we can get molecular back for the targetable things in 7 days. And then there was a new product that came out and we said, and we tested each time, say, hey, does it actually come back reliable in this amount of time? Yes. Okay, we'll continue that. Now there's a new product that came out that's actually, everything comes back in 5 days. Well, reliably in 5 days. And so we tested it saying, hey, we think this will work. Does it work? And we're getting those. So we're getting molecular back in 5 to 7 days in the community commercially, right? And so again, this is about getting to the same results of saying we want to have the molecular to make decisions, but we have to think differently because we don't have a molecular lab on site. And so I'll use that data then to basically help select saying, hey, who likely is going to be an induction candidate, and then get them to, like, for instance, Dr. Traer, my old mentor at OHSU, I know you've talked with recently, or someone who will potentially give them induction chemo, or if not, they'll stay local and get treatment. Now, if they, let's say they're a transplant candidate, so they've been through that first initial treatment, whatever it is, they've come back to me, or they're stayed with me, they're in remission 1, then I'll refer them to OHSU, and they'll be getting that transplant process ongoing while they can get continued treatment. So one of the big things about I always tell the patients I treat is that, hey, first goal is to get in remission. Second goal is to stay in remission, long and short term, right? So the first goal is once we're in remission, that's when the transplant stuff is really ramping up to say if they're a transplant candidate or they're needing transplant. But in the interim, we're doing additional treatments, whether that's chemo, whether that's HMA, venetoclax, whatever it is, to maintain that remission while we're waiting for transplant workup to be completed, find a donor, and to be ready to go to transplant. So all that intermediate care is going to be done here. So labs, transfusions, supportive care in terms of prevention with infection prevention, all that's going to be done locally by me with coordination with the transplant center. Say, hey, what's the timing of it? Do we need further therapy? What's the timing of transplant? Back and forth communication. Again, connectedness in that way to make sure that care is coordinated locally, and then when they're ready to go to transplant, then they'll go up to Portland for their transplant. Now, when they come back at 3 months, so they're there for 3 months, then again, there's that connectedness on the back end too as well. So they'll come back from transplant, and I'll help coordinate their post-transplant care. And so at that point, again, same thing, labs if they need transfusions, and then I'll work with all the post-transplant care stuff with their transplant physician. So I'll be seeing them more frequently, and then they see intermittently, they'll see their transplant physician at that point for needed touch points to monitor disease.
That is great. So what are some challenges that patients may face being treated in the community setting?
Yeah. And I mentioned this a little bit about transfusions being so things like transfusions may not work the same way as in the academic setting because we do not have, like, for instance, a blood bank on site here, right? So the blood bank is at the hospital, and so they do not have the ability or bandwidth to do same-day transfusions. And so you may get your labs one day and a transfusion the next day or the day after, right? And so, as I said, that's why we've come up with creative solutions of saying, hey, maybe increasing the parameters slightly to when we initiate transfusion, knowing that if their platelets are 15 today, they're going to be 10 tomorrow, right?
Right.
And so not waiting until they're actually less than 10,000, which would be normally what I would shoot for. So that can be one of the challenges. In terms of going there for some things like induction therapy can be a challenge, although I think the way we do it minimizes some of those challenges, but being in the hospital for a month is not easy.
Yeah.
And so I think that's one thing that is a consideration. And I think, resources, I think we do a really good job of using our resources that we have, but it's different time-wise in an academic setting than it's a community setting because we have more patients. But I think one thing I've been, I strive to give my patients the same level of care that they would get in an academic setting. And so if that requires more visits, we make it work. And so I think we do everything we can to give, equal quality care. And I think we do a pretty good job of that here in a lot of ways. You have to have a good support system if you're going to do it. I think that's what people get scared of, is that support system. But I can at least speak for WCI. We do a very good job, I think, of having those additional support services around the patient to help with some of those navigation things.
And I would think then going also a couple hours away when they do need to go up to Portland, there's financial and transportation issues as well.
Yeah, it can be for sure. I mean, I would say I think the hardest thing for patients often is it's just the fact of being away from home.
Yeah.
I will say my academic partners that I work with are very good from a social standpoint of helping find housing and helping find some of those financial things. So I want to make it completely trivial because it is a concern, absolutely. But what I find almost is a more consideration, which I would feel the same way, is just being away from home for 3 months. Yeah. And so being, outside of your normal setting, your normal support system for 3 months is not easy. But I work with really good transplant partners who do a very good job of navigating that with patients. And,
that's great.
And then we work from both ends. So we have social workers here who work on our local level, and then when they're there, their social workers work on that level. And they come back, the social workers are still here and ready to help them when they return home. So
that's great. It's good that there's a large amount of support there for patients, because I would think that getting diagnosed when you live really far away from the nearest major treatment center can be unnerving a little bit. I grew up in an area that was 3-4 hours away from a major hospital, and I saw a lot of people have to move temporarily for a few months, and so it's good that you have that support system there. Now, with those challenges that may come along with that, what would you say to AML patients and their families in more rural settings to give them hope after a diagnosis?
Yeah. I mean, I think the big thing about where we're at now with AML care is that we're getting more and more targeted options, and we're getting more and more oral options, right? And so we're getting better at finding ways to deliver care that doesn't automatically require forever, I'm admitted every time I need chemo, right? And I think so that is, I think, one thing that's evolving. It's going to continue to evolve, that we're trying to push of how do we give care farther out, right? I think one thing I would encourage is that you really want to find, if you're getting care locally, is find a good physician partner. If someone locally knows like AML well and champions it, like that's my desire above all this, is I want community champions of AML wherever it is, whether it's our center or wherever else, is that I think we need more doctors who want to do like aggressive blood cancers in settings that have not been the traditional setting for that. And it doesn't mean you can do everything, but you can do 90% of it, and you're doing a lot of good by being able to do that. And so I think that's one step. But from a patient's perspective, I think one of the big things is, it's never wrong to ask for a second opinion. I'm never offended. I do a lot of AML. I'm never offended when my patient asks for a second opinion. And so if you're concerned about saying, hey, I'm not sure if I can get the care locally, then it's absolutely reasonable to go to somewhere else to say like, hey, what needs to be done, right? But I think also pushing your local doctors to have collaborations with wherever you're going to try to push to give local care. I think that's very important for patients to get as much locally as they can as well too. I think both ways are true. We want to push our local systems to do better, right? And find ways to do better. And I think that's one reason, I've spent a decent amount of time of trying to think of, hey, how do I be a resource for my local oncology physician in Medford or Coos Bay or wherever? And I'm always willing to pick up the phone and help someone locally. And in a lot of ways, I actually understand better how to give care in those communities than the academic centers, because I live in one, I work in one, I understand some of those restraints that go along with it. And so the more of us that are willing to do that and wanting to do that, I think we're going to have better success in helping people stay locally as much as possible, but also making sure they get the outstanding and correct care that they need.
Absolutely. I mean, definitely not everyone in this country lives near a major treatment center, so it is important for these local clinics to be able to provide good quality care, and also with that support system to be able to help address those challenges that may come with this. Now, you mentioned a lot of current treatments, and then some that are a little bit in the pipeline still, like menin inhibitors. What in particular are you very excited about with upcoming AML treatments?
The combination therapies that we're starting to see are inducing really high response rates, and we're learning to harness their power. So we see that they treat disease really well. They also treat normal counts really well. And so we're seeing a lot of low counts. And so we're learning how to try to balance those things. So I mentioned earlier the FLT3 inhibitors, and especially in combination with hypomethyl and venetoclax, we're seeing very high response rates in that population, approaching even 90% or higher complete response rates. But it's still being worked out of what's the right dosing, when do you stop, and things like that. That's why it hasn't hit active standard of care yet, but is an active area of research is still ongoing. So I think that's something you're going to see. Combination therapy with FLT3 inhibitors is going to be something we're going to see in the near future, especially as if we can give someone that therapy and they have less side effects potentially from that, and then we know that they're going to potentially need transplant because a FLT3 ITD positive patient is at least intermediate risk, then you may be able to be an avenue for an easier way to transplant, and from that standpoint. And I think, I mentioned combination therapy with menin is going to be a big one. That's going to be an active area of potential growth in the AML space. I think that's probably the two biggest ones we see right now. There's going to be combination, obviously, evaluations with IDH plus other stuff. So all these direct targeted things often start as single agent and then combination, and say, is the combination better than doing one alone? And often it is. But I think those are the things you're going to see a lot of, is more targeted therapies are going to be down the pipeline, and targeted therapies then adding it into concurrent therapies is what you're going to see.
That's great. Well, that is so exciting, Dr. Fletcher, to hear all about that. And I know patients watching know that, AML still needs a lot of help in the treatment space. And so it's really great to hear about all the new treatments, and then things like menin inhibitors and combination treatments coming down the pipe that are, working. And so that is so exciting. And so I would like to thank Dr. Fletcher for joining us and telling us all about AML treatment in the community oncology setting. Now, if you would like more information on acute myeloid leukemia, be sure to visit the link below. Thank you for joining us, and we'll see you on the next episode of Hematology Horizons. Take care.